Hello, everyone. Indeed, my name is Fabian Proft, and it's a real pleasure to be here with you today. And Fernando, I much appreciate your kind introduction and also inviting me, because it will be a pleasure to speak with you today about new treatments in axial spondyloarthritis with the catchy title, The Newer the Better. I'm a rheumatologist working in the Charité University Hospital in Berlin, Germany, and I'm happy to present you the most exciting data that has just been presented at the EULA in Copenhagen and to discuss them with you afterwards. So here are my disclosures. And when we're speaking about spondyloarthritis, you all know that this is a larger group subsuming more or less similar disease patterns. And I will focus on my talk today on the predominantly axial manifestations called axial spondyloarthritis, subsuming the earlier or milder form of non-radiographic axial spondyloarthritis and the more progressed radiographic axial SPA, formerly known also as ankylosing spondylitis, which from my belief really belong to the same disease spectrum, even though not all patients with non-radiographic form develop the more severe phenotype of radiographic axial SPA on the long-term run. And I think this will be something very important for the research agenda to dissect which patients from the non-radiographic stage are at risk to develop the more severe phenotype. So when speaking about treatment, I think we all use international treatment guidelines. And here the relevant ones are the 2016 update from the ASIS and EULA management recommendations for axial spondyloarthritis, by this time convened by Desiree van der Heijden and published in 2017. And as you all know, some things changed after this was implemented and presented. And I want to discuss this with you today. So when speaking about the management recommendations from 2016, we have also the division between predominantly axial disease and mainly peripheral disease, but all in axial spondyloarthritis. In both cases, you start with an NSAID treatment and of least 2 cycles in the maximum tolerated dosage, and you combine this with non-pharmacological treatment with education, exercise, physical therapy, rehabilitation, meeting with patient associations or self-help groups. In case of peripheral manifestations, also local steroid injections or sulfasalazine as conventional synthetic DMARD can be tried. But in case this fails, or we have predominantly axial manifestations, second-line therapy would be to start with a TNF inhibitor or IL-17A inhibitor, and only as additional therapy, analgesics or a surgery should be considered. So, but what has changed since 2016? In the old guidelines from 16, recommendation number 9, and we will get back to this at a later stage, is still BDMARD should be considered in patients with persistently high disease activity despite conventional treatments. And the current practice is to start with a TNF inhibitor. Can we still say so 5 years later? And can we really apply a one-size-fits-all to all our patients with axial spondyloarthritis? I would answer both questions with a clear no. And at the EULA in Copenhagen, Sofia Ramiro presented the ASA's EULA recommendation update for 2022. And I will quickly go through all of this, but I will focus especially to the new changes that occurred when compared to the 2016 update. So we still have 5 overarching principles, and they all remained unchanged to the previous version. Then we have in total 13 recommendations. And when we are looking at the recommendations one by one, the number 1 treatment recommendation did not really change. There was only a slight adaptation for the wording that now speaking about extra musculoskeletal manifestations. And I think this is also something from the terminology that we should keep in mind. And second and third recommendation remained unchanged. For 4 and 5, both was only slightly adapted from the wording. So it was called physiotherapy instead of a rehabilitation. And also the wording about the NSAID use was slightly adapted. Here, now recommendations 6 to 8, they all remained unchanged. When we are looking at the figures, and this is graphically adapted, and otherwise there's only one significant change, and this is that for measuring of disease activity, the BASDAI was deleted and fully replaced by the ASDAS. And I think this is making sense because we all know that the ASDAS is working better, predicting high disease activity and also predicting future progression on the spine under treatment. So I think we all should try to use the ASDAS in our clinical routine. And what also has been encompassed in the treatment recommendation, or will be in the full manuscript, is that you can also calculate the ASDAS by using a quick quantitative CRP assay, which enables you to have the ASDAS value based on the CRP within 2 minutes after blood drawing, and you only need 1 drop of the fingertip, 1 blot of drops. So this is very convenient, and this is how we are assessing the ASDAS in our center. This is then called ASDAS Q, and we have the result for the ASDAS after 2 minutes. So really making treat to target based on the ASDAS possible in clinical routine, but also in the future in clinical trials. The rest remained unchanged. So when looking also on the treatment algorithm figure, we already said that when the recommendations 9 and 10, and we remember that the introduction was recommendation 9, where it was said in 2016, current practice would be to start with the TNF. And this was changed because something has happened. And also JAK inhibitors, first with upadacitinib, but then also tofacitinib, got approved by EMA, treating radiographic axial SpA with high disease activity despite conventional treatments. So the treatment recommendation now states that either TNF, IL-17 or JAK inhibition should be considered in patients with persistently high disease activity despite conventional treatments. But current practice is to start either with a TNF inhibitor or an IL-17A inhibitor. And there's one really new thing about the treatment recommendations, and this is also referring to the one-size-fits-all concept, because recommendation number 10 deals with extramusculoskeletal manifestations and specific patient phenotypes, stating that if there's history of recurrent uveitis or active IBD, Crohn's disease or colitis, ulcerative colitis, the preference of the treatment should be given to a monoclonal anti-TNF antibody. And a patient with significant skin psoriasis, an IL-17A inhibitor should be preferred. Also, when considering treatment effect, after at least 12 weeks of treatment of both biological DMARDs or targeted synthetic DMARDs, also again, only the ASDAS by ASDAS clinical important improvement should be used. Recommendation number 11 is also new and makes sense from my point of view, because here it's highlighted that in the absence of adequate response to treatment on biological DMARDs or targeted synthetic DMARDs, this should trigger the re-evaluation of the diagnosis and the consideration of presence of comorbidities for this case, because maybe the sacroiliitis that we saw in the X-ray was rather due to mechanical induced osteitis condensans ilii, and therefore the patient did not respond to our biological therapy. Or the patient has concomitant fibromyalgia, so the BASDAI score is always high. And even though the objective signs of inflammations improved dramatically, the high disease activity, as measured by the PROs, persisted. And so I think this makes sense that if a patient is not having adequate treatment response, this should trigger reevaluation of underlying diseases or differential diagnosis. And this is also highlighted here in the algorithm, what we have already discussed about the ASDAS as the positive and plaster positive rheumatologist opinion, switch to another BDMARD or JAK inhibition if the patient fails to adequately respond. And this is what is mentioned now in the treatment recommendation number 12. And this is also new, that it is said if a patient fails on either biological or target synthetic DMARD, switching to another mode of action. So either to another BDMAT in case of first-line TNF, switch to IL-17A, or to a JAK inhibition should be considered, even though we need to say that for this, the evidence is rather low. And I think this also highlights our research agenda for the future, so that we need strategy trials. What after the first TNF inhibitor fails? Should we continue to the second TNF? Should we switch to IL-17, or would it have a preference to switch to JAK inhibition after first-line failure of TNF? The number 13 remained unchanged. So if a patient is in sustained remission, tapering of a BDMAT can be considered, even though since the last update in 2016, we have now better evidence for this statement. Number 14 and 15 remained unchanged. So when we update now the treatment algorithm, we can say that the second line treatment after first line failure of NSAIDs and non-pharmacological treatments now includes JAK inhibition and states that current practice is to start with a TNF or IL-17A inhibitor. And in case of treatment failure, following a first biological or targeted synthetic DMAT, switching to another mode of action should be considered. So the conclusions. The criteria for the start of a biological or targeted synthetic DMAT now should be based only on the ASDAS as selected high disease activity criteria. This can be perfectly done by the ASDAS-Q based on a quick quantitative C-reactive protein assay. The indication for biological or targeted synthetic DMAT for either TNF, IL-17A or JAK inhibition and current practice according to the recommendations should be to start with a TNF or IL-17 inhibitor. Extramusculoskeletal manifestation should guide our therapeutic decisions, and in case of recurrent uveitis or IBD, a TNF monoclonal antibody should be preferred, and in the cases with significant skin psoriasis, IL-17A should be preferred in those patients. Further, a treatment failure should trigger re-evaluation of the diagnosis and the consideration of the presence of underlying comorbidities, for instance, as fibromyalgia or mechanical induced degenerative spine disease. And if AxSpA is confirmed and it is said that it is active and the first line treatment failed, switch to another mode of action should be considered. And in case of a biological DMAT is reaching sustained remission, and I think this should also be the case for targeted synthetic DMATs, even though we have no evidence on this, tapering and especially prolonging the interval should be considered. So taking together the EMA approval status for biological and targeted synthetic DMATs in axial spondyloarthritis when looking at ankylosing spondylitis or radiographic axial SpA, we only need first-line failure according to the EMA, and then we have 5 TNF inhibitors, 2 IL-17A inhibitors, and 2 JAK inhibitors as approved treatments available. This is slightly different for the non-radiographic phenotype, because here we also have to have failure on first-line therapy and objective signs of inflammation, so either elevated CRP and or a positive MRI. Then we have only 4 of the TNF inhibitors because infliximab is only approved for radiographic stage, and 2 IL-17A inhibitors approved for the non-radiographic axial spondyloarthritis phenotype. So what are the emerging treatment options, which should be in our armamentarium in the future? And here I also want to highlight what has been presented at EULAR. And here, first one I want to highlight is bimekizumab. Bimekizumab is a monoclonal IgG1 antibody and it's a homodimer for IL-17F and A. So it's a homodimer. And I think we all know that this has been already approved for skin psoriasis and also showed promising data in phase 2 study for radiographic axial SpA, and also very promising data has been recently presented at the EULAR for psoriatic arthritis for PSA in a phase 3 trial. And so in the in the Be Mobile 2 study, they wanted to assess the efficacy and safety of bimekizumab versus placebo and active axial SPA patients with radiographic phenotype over 24 weeks. So when looking at the study design, we had a little bit above 330 patients that were randomized on a 2-on-1 basis to either bimekizumab 160 milligram every 4 weeks versus placebo. And the primary endpoint was the ASAS 40 response at week 16. Patients had to have radiographic axial SpA, had to have active disease, still defined as a BASDAI value above 4, and needed to fail on first-line therapies. They needed to be, they were only allowed to have maximum of 1 TNF failure, and they were not allowed to have active IBD or active uveitis within 6 weeks before baseline visit. When looking at the patient characteristics, we can say that we have quite a typical radiographic axial SpA cohort. In both groups, HLA-B27 positivity and about more than 80%, predominantly male patients, and high disease activity, which was also one of the inclusion criteria. And I think it makes sense that we are saying that roughly 15% of the patients were experienced with a TNF failure. So when looking at the primary endpoint, the ASAS 40 response at week 16, we can see clear superiority with an ASAS 40 response of about 45% for bimekizumab. And I think when especially looking at the delta between the treatment and the placebo group, I think that we can say that this is quite in line what we know from either TNF, IL-17, but also from JAK inhibition. So I think we can say that this will be quite effective compared to the same efficacy from all the previous studies, even though these are different studies and no head-to-head studies yet. And here also over time, we can see that there was a very rapid response on bimekizumab, and also for the patients that were switched at week 16, they also had a very rapid response after switching from placebo to bimekizumab. Yeah, I think here we don't have to spend too much time, which is also important that in both groups, in the TNF naive patients, but also in the experienced patients, the results look quite similar, even though there was slightly lower response in the experienced group, but the delta remained the same. Also, when looking at objective signs of inflammation, we can see that the CRP based ASDAS was going down dramatically and quickly, and it was the same for the patients that switched from placebo to verum at week 16. And also here, the ASDAS disease activity states from high and very high disease activity changed over time to low disease and inactive disease at week 24. Also very important, as another sign of objective inflammation, we see that also the MRI activity significantly decreased in the treatment group as compared to the placebo group. Safety is always a very important matter in new studies, and there were the safety study data was quite consistent with the existing data from the previous trials, but also what we know, and this is mainly nasopharyngitis and oral candidiasis, which could all treated locally. So no new safety signs, and which might be of relevance could be that we had 4 cases of uveitis in the placebo and no case of uveitis in the bimekizumab group. So this might be something that we should look out in the future. And here, this is also very important because this is the Be Mobile 1 study that I'm now speaking about. And here, this is very similar study design, almost went parallelly to each other, but this is in the non-radiographic group. So if a patient was not fulfilling the modified New York criteria, but had the diagnosis of axial spondyloarthritis, active disease, and either active sacroiliitis or objective signs of inflammation by CRP, and was failing on first-line therapy. They could be included in the B-Mobile 1 study. Here it was on a one-on-one basis, either to placebo or bimekizumab, and the rest remained quite similar. And here also quite typical cohort of non-radiographic axial SpA. We can see that it was a rather equal distribution between males and females. The rate of HLA-B27 positivity was slightly lower, and also here the rate of previous TNF exposure was a little lower, as we have just seen in the B-Mobile 2 study. In roughly 1/3 of the patients, either both CRP and MRI was positive. In almost 50%, only MRI was positive, and in 1/4, the MRI was negative, but CRP was elevated. And when looking here, I think this is again the B-Mobile 2 in radiographic axial SpA patients, and here depicted the B-Mobile 1 and non-radiographic patients. And we can see that the treatment efficacy seems to be equally effective over the whole spectrum of axial spondyloarthritis, which is another argument to stop splitting between radiographic and non-radiographic, and especially phase 3 trials, but rather think about the whole spectrum of axial spondyloarthritis and take them all together. So on this data, I think that bimekizumab might be an approved and very interesting treatment target in the future, especially when we consider that bimekizumab, from all that we currently know, seems to be the most effective treatment for skin psoriasis that we have. So I could imagine that in the future, if I'm seeing if the mode of action is approved and I'm seeing a patient with severe skin psoriasis, I would slightly change the recommendation that has just been presented at EULAR from IL-17A inhibition, that in patients with axial spondyloarthritis and significant skin disease of their psoriasis, I would then maybe consider to switch to IL-17A and F inhibitor with bimekizumab. So also another emerging treatment target that was presented at the EULAR is upadacitinib in the non-radiographic axial SpA group. We all know that it is approved for radiographic axial SpA, and here Philip van den Bosch presented the efficacy and safety data of upadacitinib in non-radiographic axial SpA patients from a phase 3 trial. And also just quickly going through the Select Access 2 study design, we had a screening period, and then the patients that were eligible were randomized on a one-on-one basis to roughly 150 patients to placebo and 150 patients to upadacitinib, treated for a very long time of 52 weeks, which is FDA requirement, and then they were switched for another 52 weeks for a year on verum of upadacitinib. But patients that were active and had a flare could also previously exit the study and were treated accordingly. So when also looking here at the patient characteristics, we need to be aware that we are speaking about non-radiographic. Again, we have rather equal distribution, even with a stronger preference of female patients. We had patients with HLA-B27 positivity, and a lower percentage that have been seen in the B-Mobile studies. And when looking at the treatment response, we can again see here the others 40 after the time of treatment were with 45 in the treatment group and 23 in the placebo group. Again, quite similar to what we have been shown from the bimekizumab studies. Here also over time, we can see quite a rapid response that were sustained over the 14 weeks of treatment. And also the objective signs here, just depicted by MRI, was significantly more effectively reduced by the verum of upadacitinib. So not very surprising, upadacitinib might be also effective in non-radiographic axial SpA, and this is very important. based on this study data here presented, I think it could be perfectly be the first JAK inhibitor that also gets the approval for the non-radiographic. And this would be of high relevance because then we would have the JAK inhibitors also approved for the whole spectrum of axial spondyloarthritis and also for non-radiographic axial SpA patients. We would then have the decision to be made between TNF, IL-17A, and JAK inhibition. Also concerning safety, it was quite a short-term data that was presented, so I think this is not of high relevance, but no new safety signals occurred during this time period. Just summing up, when also looking at the GRAPPA treatment recommendations, I don't want to go into detail, but when looking here, we have the treatment recommendations based on the most prevalent phenotype. And when considering the 2016 ASAS-EULAR guidelines, we had a one-size-fits-all concept. And I think this was a dramatic step forward that with the now presented ASAS-EULAR recommendations, this was an important first step and to have a rather personalized treatment approach, precision medicine, saying that patients with either active IBD or recurrent uveitis should be treated with a monoclonal anti-TNF antibody, and patients with severe skin psoriasis should be preferably treated with an IL-17A inhibitor. So this is just to give you an example how I think the treatment decision should be made in the future, that we have our patient with spondyloarthritis, we are looking what is the most entities that the patient is having. So we have axial SpA patient also with enthesitis, but complicated by Crohn's disease. So then what could be our treatments? Oh, okay, so I go for this one because this is available in my country. And here also costs are reasonable. And therefore I would go for this choice or this choice or this choice. So I would like to thank you very much. And now I'm happy to answer any questions that you might have. And yeah, thanks again for the invitation. It was a pleasure speaking with you today.
So thank you very much, Fabian, for your excellent talk. And well, we celebrate that we have more and more treatment in axial spondyloarthritis. And my question is, what place do you think that will have or have nowadays the JAK inhibitors in spondyloarthritis?
This is a very tricky question, I have to say, because I think first we don't have any head-to-head study data. And when we are just comparing what we have from the phase 3 trials and trying to compare different studies with each other, I think that they are equally effective to both TNF and IL-17A. And what we just saw also most likely what we have seen in IL-17A and F with bimekizumab. But it's not only about efficacy, as we all know. And I think also in our axial SpA patients, we cannot neglect the safety issues that were just presented in the oral surveillance study data. But also we have to take into account that when we are looking at the study data, the mean age was 35, 40. So I think these are not the old RA patients that were with high cardiovascular risk factors that were included in the oral surveillance. So I'm also a bit reluctant to just say that what has been observed in oral surveillance can be directly implemented in our axial SpA cohort. So I'm still using them with care. And I think also because we have other modes of action available that seem to be equally effective, I had the honor to be also part of the ASAS-EULAR task force. And so I was in full agreement saying that in a patient with, I don't have a strong preference or a strong need for JAK inhibitors, and this is the first biological or targeted synthetic mode of action. This is also how I handle in my clinical routine. I start with either TNF or IL-17. But we do also have patients that have not showed quite good efficacy on either of the treatment modes, or they say, I can't do self-injections. I need to have an oral drug. And I think therefore it's also very important that with the JAKs, we have this now available in our treatment armamentarium.
Great, very clear. Rodrigo, do you want to ask something?
Yes, first of all, thank you very much, Fabian, for your comprehensive presentation and your updated from axial guidelines. And my question is, in your opinion, what is the more important advantage for bimekizumab against others IL-17 blockers and ixekizumab or secukinumab?
I have to say, I just don't know perfectly clear. But because I have not used them in my actual SPA patients yet, I was involved in the study, and so I included some patients also in the B-Mobile studies, but this was rather rare. And I think what we really need are head-to-head studies where we can see, especially in this patient population, is one or the other mode of action more effective in the same treatment population. But on the other hand, as I said, and this is something that we can use from the psoriasis trials, because here bimekizumab really outperformed the existing treatment and showed that it is on skin psoriasis dramatically more effective than the existing mono inhibition with IL-17A. So if I have a patient with axial spondyloarthritis and very severe skin disease, and bimekizumab is approved, and from all we know seems to be equally effective, then I think this would be the patient population where I would consider this an appropriate option.
Great.
Thank you, Fabian.
And just for the time, we make one more question. What do you think that was the main change in the new ASAS recommendation? What do you think about it?
So I think what has changed since 2016 is especially that now JAK inhibitors are also included. I think this is very important that the approval status includes all available treatment options. Secondly, that also the sentence current practice would be to start with a TNF inhibitor was broadened, that now it says TNF or IL-17A could be first-line treatment option. And I also think that if a patient is not responding well to therapy, first it makes sense to reconsider, is my diagnosis correct, or is there anything else that I'm currently missing? And if this is not the case, then it might make sense, because we have now different treatment modalities available, to just try another mode of action. And so if a patient is not feeling well on the TNF, why not trying IL-17A? Because maybe this solves the problem, or go for a JAK inhibition. And I think these were, from my point of view, the most important changes.
Great. So thank you again, Fabian, for your time and for your excellent talk. And we now hear the question of the public of Panlar.
Yes, thank you again for inviting me, and I'm really happy to next time be in person at the meeting.
Yes, obviously.
Yes, thank you.